All right. Good evening and welcome. Great to see so many people joining us, and thank you for giving up your Monday night to be with us on the first day of National Diabetes Week. I'm Justine Kane, the Group CEO of Diabetes Australia, and I'd like to welcome you all very warmly to our first ever National Diabetes Week Great Debate Series. This week we are kicking off Australia's biggest conversation about the impact of diabetes in this country. We're tackling all of the hot topics around the diabetes epidemic, the single biggest challenge confronting Australia's health system. And we're starting with one of the most important issues facing our community: quick and affordable access to care. That includes healthcare services, diabetes technology, medications and treatments. But before we begin, I'd of course like to acknowledge the traditional owners of the lands on which we meet. Diabetes Australia acknowledges Aboriginal and Torres Strait Islander people as the traditional owners and custodians of this country. For me, the Turrbal and Yagara people. We recognise their connection to land, waters, wind and culture. We pay the utmost respect to their elders, past and present. We extend that respect to all the Aboriginal and Torres Strait Islander peoples joining us here today. We recognise that Australia is made up of hundreds of different Aboriginal and Torres Strait Islander groups, each with their own histories, cultures, language and belief systems. Their relationship with country remains of the utmost importance, as it is the foundation of culture, family, kinships, songlines and languages. Diabetes Australia is committed to improving health outcomes for all Aboriginal and Torres Strait Islander people affected by diabetes and those at risk. I'd also like to very warmly welcome our participants and panellists today, including my co-host and moderator, Dr. Norman Swan, AM, producer and presenter of Radio National's Health Report and a multi-award-winning producer and broadcaster. Brett Fenton, Diabetes Australia and Australian Diabetes Educators Association board member, credentialed diabetes educator, and an individual who's lived with type 1 diabetes for more than 30 years. Brett is currently a nurse manager of diabetes services at the Central Coast Local Health District in New South Wales. We also warmly welcome Anne Bush, Vice President of the Australian Diabetes Educators Association and a registered nurse and credentialed diabetes educator with more than 30 years' experience in the field. The wonderful Professor Glenn Mabley, a staff specialist endocrinologist at Blacktown and Mount Druitt Hospitals and Director of Western Sydney Diabetes. Our very dear friend, the Dr. Conrad Kangaroo, Regional GP and advocate for primary health care and member of the Diabetes Australia Health Professionals Advisory Council, and a gentleman who is very giving of his time to Diabetes Australia on a regular basis. And finally, but absolutely not last, Jackie Goldston, a marketing manager at Unique Health Products and mother of Freya, who's done a lot of work with Diabetes Australia in the past. Freya lives with type 1 diabetes. So thank you all very much, panellists. We're really excited to hear what you have to say. Our reason for being here today. We are living through a revolution in medical research. I think you'll all agree with that. New breakthroughs are leading to new medicines, treatments and technologies that are reducing the impact of diabetes-related complications. But these treatments only work if the people who need them can access them and know about them. That's why regular health checks, as I'm sure you all are aware, are so incredibly important. Australia has one of the very best world-class health systems, but people living with diabetes are confronted by a range of barriers that can prevent them accessing the care they need. Many people miss out on important checks such as eye checks, kidney checks, foot examinations and other types of tests that can keep them healthy. I'd like to open the conversation by seeing if we've got Norman Swan. Now, Norman's been having a few challenges, but he's absolutely with us. Welcome, Norman. I'm going to start with you, if that's okay, and open the debate.
Yeah, I will. Yes, thank you very much, Justine, for that introduction. I apologise to everybody else that I'm late. I'll just assume that it's my klutz-like non-abilities with electronics. We've only been doing these electronic webinars, virtual webinars, for 4 years now, 3 years. So eventually we will get it right. So thank you very much indeed.
No, it's all good, Norman, and you're right on time. It's perfect. So I've got a leading question for you before I hand over to you to moderate the most of this debate. How do you think we can improve access to diabetes care in Australia?
I think, and I think that almost everybody on the panel will be able to talk about this, is that we can only do it through primary care. There'll never be enough credentialed diabetes educators. There'll never be enough endocrinologists. There'll never be enough hospital outpatients. It can only be done through primary care. And Glenn, I'm sure, will talk to us about what's going on in Western Sydney, and there are other models going on as well, including in Queensland. And it will require reform of primary care. So credentialed diabetes educators are primary care healthcare practitioners. GPs are, nurses are, diabetes nurses are. We've got to actually move, and I believe we've got to move endocrinologists into primary care too. And that's one of the models. That's the Inala model that's out of Princess Alexandra in Brisbane, where you take endocrinologists away from the hospital out into the community, and you start to develop a high level of expertise amongst GP teams, and you pay the team as a team. Get away from fee-for-service. Fee-for-service does not work. You cannot do this by fee-for-service. You've actually got to create team-based payments so that everybody gets well remunerated for what they do, but independent of the time that they spend, so that the patient gets the access that they require. And I'm sure Anne and others will talk about this, but you asked me my opinion. I'm not supposed to have an opinion as the moderator, but you asked, and I've said primary care and primary care reform. So look, thanks very much, Justine, and welcome to everybody. Welcome to everybody. Tim Perry will take your questions as we go along. So just every time you've got a question, put it in there, and Tim Perry from Diabetes Australia will take your question. We'll come back and we'll have moderated questions as we go along. I want to start with you, Jackie, in terms of timely and affordable access. What are the key issues from your point of view as a consumer?
As a consumer, actually, I thought it was very interesting what you were saying there about local access. We have, and I'm on the Sunshine Coast in Queensland, but my daughter has always gone to Brisbane because when she was diagnosed, the local hospital didn't actually have the facilities to treat a baby. So we were rushed to Brisbane Emergency. Back then it was the Royal Children's. And then over time it's become many other names, and we've moved over to the Queensland Children's Hospital. So we have been in the public system for 14 years. And I can only say that it has got, the staff are amazing, but access has gotten worse. So we actually haven't had an appointment since December. And what are we now? July. So we have just seen for the first time a credentialed diabetes educator rather than going through and seeing an endocrinologist because we just simply can't get in. So I hear this a lot. People are coming out of the public system, having to take extra money out and having to actually pay when they can't afford private health necessarily for private services with parents with type 1. So that's one of the big challenges I'm hearing about. That coupled with access to diabetes technology where they just can't get it because there's not enough free access to pumps. So they're having to spend a lot of money or sacrifice food, sacrifice other things to actually get private health insurance to access pump technology. So I guess they're two of the, off the top of my head. We can talk about drugs later because access to good insulin is another issue for us.
But it's also, is it not, about, essentially getting access to Anne Bush to the anticipatory care that people need on an annual basis?
Well, for children with type 1, that's actually supposed to be every 3 months, not annual. So kids with type 1 are supposed to have an update every 3 months, and potentially even more often. I mean, I have just been blown away by having a credentialed diabetes educator available to me, which I pay for, but it is so amazing to actually be able to text someone and say, my daughter's levels have gone crazy. I don't understand why. And we talk about puberty, and she'll actually respond to me immediately or within a couple of hours rather than a week or two. So that is something that I didn't know existed and is really, really important.
Indeed. I mean, Anne Bush, coming to you, the statistics are extraordinary. Justine alluded to them. Half of people, I mean, I realise that there's a degree of intensity that's slightly different with type 2 versus type 1 diabetes, and type 1 often gets shifted into the corner in the current debate. And both are important, but overall, half of people not getting their HbA1c done regularly, 29% not getting their blood pressure measured, 51% not getting their cholesterol done, 73% not getting their renal function measured on a regular basis, 41% not getting their weight done. When even with type 1 diabetes, particularly for type 2, it's the control of the risk factors that make a difference to your future. What's going on here? How do we make it better?
I think one of the issues is access to their GPs now. It's very difficult to get into your GPs, who are the gatekeepers of all of these complication checks that need to be done. If they can get access to their GP, they probably can't afford that $100 gap fee that they have to pay now to see the GPs. And so we also know that people with diabetes, only about 37% of them are getting their team care arrangements done. And if they're not getting a team care arrangement done annually, then they're not going to be able to access the Medicare rebatable allied health services either, which, I mean, it's a measly 5 visits that have to be shared amongst all of the different allied health. And to tell you the truth, living with type 1 diabetes, you need to see your diabetes educator, your credentialed diabetes educator, more than 5 times a year. And even someone with type 2 diabetes with complications needs to see us more than 5 times a year. And they'll also probably need to see the podiatrist more than 5 times a year. But we do have to share those visits. So it's the system as it stands. I think we just don't have enough staff, whether that be GPs, credentialed diabetes educators, podiatrists, dietitians, to go round, and we're not being remunerated properly, so it's not encouraging more new staff to come on board.
Brett, do you agree?
Yeah, I think that's right, Anne. And so, well, firstly, I think, as you mentioned earlier, Norman, the growth area is going to be predominantly in primary care with private diabetes educators and endocrinologists, etc. Yeah, a whole lot more money going to public health, and we won't see a huge growth in diabetes educators in public health and endocrinologists in public health, I don't think. But unfortunately, that then shifts the cost onto people like Jackie when she's looking after her daughter, and she's mentioned she's had to go and see a private diabetes educator, credentialed diabetes educator. And then, to Anne's point, there's not very many Medicare billing item numbers for credentialed diabetes educators. And then aside from that, what we know is that there's...
interrupt you, Brett. I mean, the plan is patient registration with general practice. So Jackie's family would be registered with their general practice. That would unlock a whole flow of payments, including to diabetes educators, and get away from fee-for-service. Fee-for-service isn't working for general practice in this area. It shouldn't be. It's probably not working. It's clearly not working for diabetes educators.
Not working.
So are we going to see the answer to this in the next year? I mean, what do you think, Conrad, in terms of what we've been talking about here? I mean, I don't get into the negative, too much into the negative here, but the reality is what we're looking for here is timely access to anticipatory care so that people live long, healthy lives, whether they've got type 1 or type 2 diabetes.
Absolutely right, Norman. And your comments earlier that it really rests with primary care. This was reflected in the report from the OECD back in 2015, when they recognised that Australia's role as one of the strongest nations in the world for not only diabetes, but also reducing the subsequent CV events, cardiovascular events associated with it, comes down to that strong primary health system. It's the same strong primary health system that got Australia through COVID as well, by the way. You got 40,000 GPs out there. Now, you're talking about 1 million Australians living with diabetes, not of all who know that they've got it. So just getting to the diagnosis But then, exactly as we pointed out, then making sure we've got those timely assessments done, those HbA1cs, the urinary proteins, all those silent things that creep up on somebody. Now, sadly, in a lot of other countries around the world, people don't actually get diabetes care until they develop complications, until they're actually in hospital, or they're losing a foot, or they're going blind, that nobody actually looks for these things. In Australia, we've actually got items there which anticipate. We know that people in midlife are going to be at increased risk for diabetes. So we've actually got tools there. If you've got somebody who's got a family history between 40 and 40 years of age, you can do the item for it. If somebody's between 45 and 49, we're all funded to be able to provide a health assessment. So in Australia, we can uniquely go looking for this before it's even present, before anybody's got symptoms.
Explain something to me, Conrad. 50% not getting their HbA1c, 29% not getting their blood pressure. That means that 70% of people are getting their blood pressure checked. 60% are having their weight checked. So look at the positive now. What's happening when they go along to the GP that only 25% are having proper kidney checks? Where's the ignorance in the system, to be brutal, that you're turning up at the GP, and we haven't even talked about eye checks at this point, and somebody looking at your retina in a consistent way. What's going on? You walk into the GP, but you're not getting all the tests you should be getting.
That's right. And sadly, and this is systemic, that even the federal government dropped the annual cycle of care incentive payment 3 years ago, which actually reinforced that for practices to be eligible for this annual cycle of care incentive payment, they had to have met all of those simple criteria through the year. Less than 15% of patients were actually meeting all of those targets. And so the government said, oh, well, if that incentive's not actually there, they dropped it altogether. When you get that type of messaging coming through the funding mechanism, that, oh, well, following through on these things doesn't really matter, it doesn't take long for the priorities to then shift within that general practice consultation as well, to just what other things that the patient actually is wanting dealt with in that short period of time. And you're absolutely right. Sometimes those silent things that nobody really recognises don't get picked up on, looked for immediately well. We have to take control of that as a profession as well. But even within general practice, we can only deal with what we've actually got sitting there in front of us. If people aren't coming to see us, we can't really go dragging people in off the street.
Glenn, you are trying to change the system. So you're working across a model field. I mean, an extraordinary 100, in the area in which you live and work, 110,000 people have diabetes, not to mention pre-diabetes, even more, out of 1 million population. I mean, those numbers are staggering. Just give us a sense of what, the sort of solutions you're working on.
Well, thanks, Norman. I think everyone's been singing a song I can very much go along with tonight. I think when you say, are we getting access, the first thing I would say is, are we getting diagnosed? Because early treatment is a real key. And we've been doing hemoglobin A1C at the emergency department, in GP practices, testing it out, and more recently at the Workers Club up at Blacktown. And we find exactly the same figures of 18% of adults with diabetes and 30% with pre-diabetes. That's higher than the prevalence rates, but that's what the numbers we're picking up. I mean, I think we believe at least 13% of adults in our patch have diabetes. So you're quite right. This can't be managed by any specialist group. And so our big focus has been in Western Sydney Diabetes for the last few years is actually building that capacity of GPs and the community providers to better manage it. And I think COVID actually, of all the things it brought us telehealth, because we all had to do telehealth during the COVID crisis. But we've continued it on. And right now, this last 12 months, we have 1,200 GPs in our patch. 600 have joined us in telehealth with the person with diabetes, along with an educator. And we've sort of nutted out a plan. And after a couple of consultation periods, the GP continues to manage. And we found remarkable results because what we're focusing on is when we see a patient with a GP, it's not just about that patient, it's about all the patients that the GP may be seeing in their practice. And on average, we've dropped this hemoglobin A1C, a measure of how well the blood sugar is in the normal range. We've dropped at 1.6%, which is quite a remarkable drop, and having people much more in time in target. We do something extra as well. We put on a CGM in all people with type 2 diabetes during this diagnostic period, and they learn a lot, and everyone learns a lot by looking at it. So I think there are different ways to approach it. Now, I want to take my hat off really to the GPs, because 600 of them have stopped their busy practice, taken the time for 30 minutes to meet us with their patient, and we've had a consultation. Now, this isn't because there is any big finance to make it happen. GPs are really dedicated to their patients and will take time out to do it. I don't think it's economically feasible. I think it's just because GPs are very concerned and they learn a lot. But that being said, 600 haven't. And we often see patients coming through the hospital which don't have their blood sugar in range, and they have all the indicators of kidney damage, eye damage, and everything else, and they're not getting easy access to their GPs, and the GPs are not finding it financially worthwhile to join in. So my big plea, I guess, is for the system to change, as you have been talking about, to enable this not to be an exception, but become the rule.
Jackie?
I think that one of the challenges which all of you have just shown is that type 1 just falls off the radar. And this whole conversation, again, for me, reminds me of why so many parents walk into a GP clinic and are so frustrated when the GP has no idea about type 1. And I know it's a general practitioner and they can't know about everything, but some of the advice that they are given, and maybe it's because it's a newly diagnosed parent, and maybe it's because they don't know what they're hearing, but when a newly diagnosed parent is at a GP and getting given advice that's for a type 2 person rather than a type 1 child or type 1 adult, there's some real problems there. And I think there needs to be funding that helps GPs to either filter these people straight to where they need to be, or to those who want to be engaging need to engage, as you're saying, Glenn, in more education. And if they're not prepared to do that, they need to be ready to push these people to the right places quickly.
I sometimes wonder, Jackie, whether GPs are actually, I don't want to it's not a question of bashing GPs, but it's obviously rarer, but there's so many different kinds of insulin, so many insulin regimes. How do you look at the chart and decide whether or not you're going to go up by half a unit, a quarter of a unit, you're going to change to a different form? I mean, in some ways, type 1 diabetes has become vastly subspecialized. So it's hard for a GP to know. It's easier for Anne and Brett to do it. They do it all the time, or Glenn. But type 1's tough. I just wonder whether. So my question really to Anne or Brett is, in terms of type 1, can this actually be a general practice issue? In other words, it's so specialized. Is it always just going to be endocrinologists, hospitals, diabetes educators?
So I think that there's, I think there's two aspects to it. So I think there's always going to be a role for credentialed diabetes educators and endocrinologists to help manage type 1 diabetes. But the reality is, and it was mentioned right off the top, Norman, I think you mentioned it, there's not going to be enough endocrinologists and credentialed diabetes educators to manage all the people with type 1 diabetes, unfortunately. We would need some miracle to see a significant increase in credentialed diabetes educators and endocrinologists. And if anything, it's an aging workforce that's probably, going to be difficult to maintain.
Can I just challenge the two of you on that? I mean, that assumption. If you got a situation where you are actually deburdening the system of people, deburdening is the wrong word to be used, so I apologize for it, but because patients are not a burden, but actually getting people with type 2 diabetes to where they can be cared for most effectively, which is in general practice. Surely there are enough endocrinologists and diabetes educators to look after type 1 diabetes. Type 1 diabetes has gone up a little bit over the years, but not a lot.
But I think Conrad would agree. We don't want to de-skill the primary care workforce. So I think Glenn's program that he's running, and we've run something similar on the Central Coast in a pilot fashion, and it would be really great to bring that to a more permanent solution on the Central Coast where I work. But we need to we need endocrinologists and credentialed diabetes educators working with primary care, with GPs, to upskill them. There's been a huge upshift in technology in type 1 diabetes, which has made it more complex. So there's, subsidised access to continuous glucose monitoring, greater access to insulin pumps linking with continuous glucose monitoring. And sometimes for some GPs and practice nurses, they'll see this type of technology and it can be very overwhelming, and we see it in hospital as well. With nurses and doctors in hospital, you would have definitely experienced at some stage going in there into an emergency department and being told all sorts of different things about how to manage the diabetes, and much of it not always correct, probably.
And Bush.
So, Norman, if I
come Anne first, and then I'll come back to you.
I was just going to say, I work in a regional area of Victoria, in several different regional GP practices, working closely. And my practice is probably about 50-50 type 1 and type 2, because we are a little bit isolated. We don't have a public hospital nearby. So working very closely with the GPs to upskill them so that they know a little bit more about some of the technology. I've got some of the GPs, I've taught them how to upload the CGM data, and now they know how to interpret CGM data working together. We've also got an endocrinologist who does telehealth, similar to sort of Glenn's program, I guess, but he does telehealth with that person's GP. And the GP there is learning a lot about the new insulins, the new technology, those kind of things. They'll often come and ask me for clarification on a few things. But if we can work as a team and we've got that wraparound care, that's the way we're going to manage the load. It's the only way we're going to be able to do it as a team.
Conrad, I've been skating on thin ice here. You'd better take over for a GP comment.
Yeah, you have been skating on thin ice, that one. Look, Brett hits a great point there, that the complexity of type 1 diabetes care has increased dramatically, and the expectations of the standards of care that we're talking about. Talking about Kellyan medals for people who have lived 50 years with type 1 diabetes. That's not anything rare anymore. That's definitely something which is a realistic aspiration for most patients. But talking about time in range is vastly more complicated than just talking about a HbA1c reading. Talking about how to manage hypoglycemic care is a whole different topic to just talking about getting your blood pressure down. So we really do recognise that, yes, now we don't want to just focus on the sugar either. That's the other part of it. That once we start buttonholing individuals into, you can only go and see your pediatric endocrinologist because that's the only person who knows how to look after you, you start forgetting that these people actually have got other needs as well. We've got a whole complex person who is not just defined by the fact that they have this diabetes condition. So there will always be an essential role for the GP at the centre of that team looking after that individual. But we do want to definitely make sure that the people who have got the skills and the knowledge and the experience who can best help with that individual's care needs do get access, but that shouldn't be at the exclusion of the GP.
Glenn?
So, Norman, our group focuses predominantly on type 2, but when we're out in GP land, we inevitably find a patient that they want help with, but type 1. I think that kids often get help with the kids' services, but once you graduate from being in the kids' hospital, that's when people tend to get lost out in the community and are really looking for help to get lost. In our program at Mount Druitt, we run a program where we get GPs into our clinic for 6 months, and they sit beside us as we do these management clinics. I reckon you could do the same for GPs in type 1 clinics and get a series or a number of people beyond just the few endocrinologists trained up to be more helpful. Many of the aspects in type 2 diabetes and type 1, there is a bit of an overlap. We use CGM in all of our type 2, and it's interpreted. I think there is a very distinct role for GPs, and we are overburdened with type 1 and we're overburdened with type 2. Let's not have this a competition between the two. They really both could be significantly helped by upskilling primary care and the community to better manage.
So Jackie, in many ways, the person living with diabetes or their carer become the expert in a sense. And I suppose the question for us all is, do the consumers know enough to be able to drive the right care? Now, if they're not, if we're talking about type 2 now, but also type 1, if they're not getting their risk factors measured on a regular basis, have we failed in educating patients and carers here?
I think for people with type,
if they were asking for it, the GP would provide it.
I think people with type 1, well, I mean, we're really lucky. I just put it out there in case my GP's watching. She's amazing. And I think we learned to...
Nice. I
know. We've learned together. I've been lucky, and my daughter's been lucky. We've had her for many, many, many years. And so because she's been the carer of my daughter as well, she's proactively learnt about type 1 and about the technology. And I think that when you have a long-term patient, a lot of GPs would do that. I think the challenge is when someone's newly diagnosed and them not knowing, for type 1 or type 2, going in and not knowing what to ask for. You're absolutely right. And I can't even imagine what it would be like being diagnosed as a teenager these days. In many ways, I used to swear and say terrible things because my daughter was diagnosed as a baby. But you know what? She's never known any different. She's grown up with type 1, whereas I see other kids coming in the teen years and that mental health support is not there anymore. I mean, we use up our tiny number of mental health plan access so quickly. The GPs are desperately trying to write another one when the date rolls over. So I think mental health is a big issue. Dietetic support, being able to find a dietitian that actually understands how to read your HbA1, well, your blood glucose monitor, the CGM, as Glenn talked about. For us, having a dietitian, and ours has just moved to the Gold Coast to work to the Gold Coast Suns, darn her. So we've just lost a fabulous dietitian, and we can't find one now on the coast who knows how to actually download Diasend, or now it's Gluco, the new version, to actually look at Freya's insulin, look at what she's eating, make a recommendation, help us with her diet so she can be normal, so to speak. And I can't imagine this would be any different for someone with type 2.
So is this any dietitian or finding a dietitian who's got the skill?
The skill. Well, actually, to be honest, the cost for any dietitian goes so quickly in the funding, so it's hundreds of dollars out of pocket after the first few visits. We're lucky we have private health insurance, but we're still out of pocket probably every visit, maybe $80 if it's an hour visit. And that's a lot of money for parents and for adults. But most dietitians don't have that knowledge with diabetes, full stop. Type 1 or type 2, I don't think. And that's another area which I think we haven't talked about yet, which I think Glenn was talking about with the CGM. It's really important to see that for both type 1 and type 2 so people can understand how their body responds, because every single person is different. Every single food reacts differently for every person. Well, not every food, but I'm sure there's so many variations.
So have we, what can we do this is a question for Anne and Brett, and I'll come to you, Anne, first on this, which is if consumers had the knowledge and created the demand, things would start happening. Because when they walk into the GPs, face-to-face or on a telehealth conversation, they would know what they need. And let's just move to type 2 diabetes, particularly to the risk factors, because they're not going to die of their high blood sugars. They're going to. It's a heart attack, or it's a stroke, or it's dementia, or it's vascular disease, which, I mean, all these problems people with type 1 get, but the burden on the community and individuals is higher with type 2 overall. What can we do in a public health sense to intervene so that people can, consumers can drive that demand? Anne?
Yeah, I think it's a very good point. I had a client say to me today he felt like he needed to do a medical degree so he can manage his diabetes. That's what he's feeling like, spending some time with me and learning about his diabetes. And it's very complex living with diabetes. And then when we throw in the people living with diabetes have to be over making sure that they're getting their HbA1c checked and their renal checks and those kind of things, makes it even harder. It's more of a burden upon them. Certainly, as a CDE myself,
I challenge you on this. Is it really that complex to know that there are 5 things you need to have done? And the GP knows.
Yeah, but on top of all the other things you have to do with your CGM and your carb counting and your dose adjustments and all of those other things that they have to need. So, yeah, I mean, it can be burdensome, but I think that's part of, as a credentialed diabetes educator, that's what we work on. We talk about the complication checks and when they're due, and my clients all know what their renal function's like. They all know what their HbA1c is because we spend a lot of time discussing what's normal. And if we see that this hasn't been something done, or I've got a referral where things haven't been done, I'll say to them, you can ask the doctor, but I'm also going to send them an email or I'm going to send them a letter just requesting those things to make sure they're being done. I know, I'm on a committee with Conrad and he's heard me say this before, and I'm skating on even thinner ice, is, surely we should be able to allow credentialed diabetes educators to be able to write these pathology requests when they're due.
Well,
that would be
interestingly, what's happened with COVID, coming back to Glenn's point about COVID, is that GPs are getting pre-consent for Paxlovid prescriptions. People are getting they're getting pathology forms written out, so they don't actually have to wait for their GP consultation to actually get the stuff done. So, I mean, it happens with COVID. Some of this could actually happen, couldn't it, Conrad, with diabetes? Is that you don't actually have to have your GP consultation to get your 3-month check type 1 or annual check with type 2.
Well, if we use these proposed My Medicare reforms properly, that should be exactly what can happen, where we recognise that I don't need to see every test result that comes through my inbox if I know that I've actually got somebody else on the team who is going through those and is able to pick out the ones that need action. But until I know that other professional is going to be as responsible for that result as I will be, I'll keep supervising them myself. And that's the way our Australian healthcare system runs at the moment, that ultimately it's the prescribing doctor who is the one who takes responsibility for the prescriptions we write, the pathology we request, the procedures we perform. The buck stops with us at the end of the day. So yes, having an engaged and an educated population, and it's not just the individuals who with diabetes themselves, it's the whole of community. So that when somebody with type 2 diabetes who is saying, I need to go and get my doctor's check done, doesn't feel like they have to plead with their boss to give them the time off to go and do it because, you're not sick. It's not like somebody with asthma who's wheezing in front of them. Or it's not like somebody with heart disease who's having angina episodes and going pale. This is somebody who is trying to keep ahead of their condition before they start actually getting complications from it. We need the whole community to say, yes, you going and getting that check is important. We'll watch the shop until you get back.
Glenn?
I think that we're at the cusp of a lot of digital solutions that we're beginning to use. Prior to COVID, we made about 100 very short 2 or 3 minute videos, the animation that really had what most of the diabetes educators would talk to patients about as a video. And when COVID came, we made that available throughout Australia through NADC. It was a real big take-up because people, if they actually pricked their finger and got a low blood sugar, they would get a message on their app to say, your sugar is low, do this. And then a few minutes later, they would get a little video that would explain how to manage hypoglycemia. There's lots of things that can be done now as we move forward to actually integrate digital education at the time that the person who has diabetes needs that information and gets it to them. And so I think we're really at the beginning of exploring and using a whole different approach of digital solutions that can actually not take over all of our professions, but actually be a really good assist.
Now, we need to talk about prevention. The system doesn't like talking about prevention, but you all want to talk about prevention because it's so important. And Jackie, it's even becoming possible that maybe type 1, this has been the nirvana here, that there's a preventive element to type 1. What we've been talking about now is secondary prevention. Until now, we're talking about secondary prevention of complications, but primary prevention, stopping the problem in the first place. I mean, Glenn, you're doing a great work with secondary prevention. What about primary prevention? Where do we need to go with that?
So, Norman, Western Sydney Diabetes actually focuses heavily on primary prevention. So we think it is the environment around us that is actually creating the obesogenic environment that is creating the problem that we have. So we have been working with councils, with other sectors, other governments, other departments on urban design to make Western Sydney a healthier place, planting trees. We know that if people walk where there's canopy, we can reduce diabetes. So there's a lot that can be done in primary prevention around improving our food supply, improving our physical activity, and improving urban design. And I think the second thing is actually getting in there early and getting a test. So we are encouraging people who live in Western Sydney and where we know that First Nations people and people from other cultures have a higher rate of diabetes to have a check. And if you end up with a result that says, I have pre-diabetes, not diabetes, if you just lose 2 kilos, you reduce your chances of getting diabetes 30% over 10 years. So I think that I'm actually not just an endocrinologist, I actually am a public health profession, and that takes over very easily in this discussion. But we need to not put stop people falling off the cliff and picking them up at the bottom, but we actually have to do something about preventing diabetes in our community. It's getting out of hand.
Brett, do you believe that the high-risk populations, that we're doing enough in high-risk populations to actually get involved in prevention? For example, I mean, do you think that with all our focus on, say, BMI and 25 being the right BMI, well, it's not the right BMI if you're ethnically, Indian or Pakistani or, a First Nations person, it's down at about 22, and therefore you're getting to be pretty overweight at 25. So when we talk about prevention, we don't seem to be, I'm talking now as a broadcaster rather than anything else, because a long time since I've been a doctor, but it strikes me is that we're giving out a one-size-fits-all message, which misses out on high-risk populations.
Well, one of the highest risk populations that we know of is women who have gestational diabetes. So they have a 50% chance of getting type 2 diabetes in the 10 years postpartum after they've had their baby. So, but I'm still not aware, whilst there's some prevention strategies available for women who've had gestational diabetes, there's no nationally funded or recognised diabetes prevention program for women with gestational diabetes. And we know, having just come out of NAIDOC week, we know the challenges that we have in the Indigenous community. And there's much work being done by Alex Brown and others in Alice Springs and remote Indigenous communities, but we're clearly not meeting the need there either. We're looking at the care plans, annual cycle of care for people with diabetes. We're getting 37% of non-Indigenous people are getting a care plan to screen for their diabetes complications. That's in people that are known to have diabetes, but less than 1% of Indigenous population are getting these care plans done. So that's for people known to have diabetes. You can only assume there'll be even less done for those who are not yet known to have diabetes, who are just at a very, very high risk. I think nearly everyone that I screened at NAIDOC Day on last Thursday would have been a high risk for diabetes. You know, that some of them were 1 in 3 chance, many of them 1 in 3 chance, 1 in 7 chance of getting diabetes, but they hadn't yet had any formal testing done. That, you know, it just hadn't been addressed. And it comes back to the underlying issues, some of the things we spoke about: access to GPs, cost of seeing GPs, GPs being really, really busy and trying to address the current problem that the person's there for, but not having time to or thinking about doing the care plans for people that have diabetes so that they can go and see a credentialed diabetes educator. So the Medicare system just doesn't fit. It's not a fit for purpose solution to managing diabetes, and doesn't support significantly preventing diabetes for either women with gestational diabetes or people at risk of getting diabetes.
Just before I come to Jackie, I mean, some community-controlled health organisations and Aboriginal communities reckon they're doing better than average because they don't necessarily have to, you know, do a care plan because they've got team-based care already, and then they've got Deadly Choices, which is an incentive system for people coming along for their checks and then for their follow-ups, which in Aboriginal communities where they have Deadly Choices, it seems to work. Jackie, I'm going to come to you and then I'm going to go to Tim to take some questions.
I'll be really quick. My point to all of that was I think what we're missing here is the stigma around type 1 and type 2. And I think we're missing, and I'm sure there's people yelling that type 1 can't be prevented. And I think we just need to be clear that type 1 at this point in time cannot be prevented. That said, and the number of times I've been asked what I did to my daughter for her to get type 1 so early. So there's a lot of misunderstanding about that. And I feel the judgment. So I can't imagine what it would be like for someone with type 2 diabetes. And I think that actually is something that impacts on diagnosis and prevention and all of those things for type 2 diabetes, because as someone who can turn around and go, there's no way my daughter could have prevented it, I can say that. But it's really hard because, I mean, I know that not all type 2 can be prevented, and I know that we haven't said that, but not all of it can be. But obviously it can be put off and slowed down. But the actual stigma that is attached to diabetes is horrendous for a lot of people. And I just wanted to, I guess, raise that because I think it makes it harder for treatment. I think it makes it harder for people to manage themselves. I think it makes them harder to ask for help because they're embarrassed and ashamed, and they shouldn't be. And I think we really have to have more conversations about that.
Well, you're a marketer, aren't you? So
I am.
What would be your message?
Well, I actually did put many, many years ago, I actually came out of Cancer Council, so I've actually done social behaviour change marketing. So one of the proposals I put to the government, having come out of Cancer Council in New South Wales, was actually a social change program, which they told me that they couldn't fund at that particular time. But my feeling is that we actually really need to look at the words we use. We need to look at the way that we approach people. We need to look at how we encourage them to do better in their lives in a less judgmental way. And I think personally, if I could sit down at a round table, I'd love to do that. And I think maybe that's one of the things we need to look at is people who have the experience in behaviour change marketing to work with the government and to work with the key bodies and actually make the right messages to get to the right people in the right places at the right time. And each age group, each demographic, it's a different message. Needs to be the right message. We need to know what that is. And I'm ranting here because that's what marketers can do sometimes, sorry. But I care a lot. I care about
inquiry into diabetes, Jackie.
Pardon?
Good timing for the parliamentary inquiry into diabetes.
It is. And it was the Labor government when I first approached them, and then it was the Liberal government. So both sides. It's bipartisan support we need on this. It's both sides of the parliament need to come together and give the funding and give the support to make change.
Let's take some questions and comments before we close. Tim, what have you got?
Thanks, Norman. Look, some great comments coming through. So thank you to everyone for dropping them. Number of sort of key themes coming through in terms of comments like we need a system that offers the support people need when they need it. A lot of discussion around integrating primary and tertiary care, and also not forgetting the importance of peer support in supporting people with diabetes. A great comment here, we need to talk to people living with diabetes to establish what the barriers are and then work to overcome them. And we've touched on a number of them tonight, and that's great. If I can include a little plug here for the survey, the National Consultation Survey that Diabetes Australia has launched just this afternoon, which is all about this. It's all about understanding those barriers. So please If you haven't already checked it out, go and do that via the website. Submit your thoughts and your views, and that'll really help what Brett's just mentioned there in terms of the parliamentary inquiry. I was going to ask the first question, but Jackie's probably so eloquently addressed it there in terms of the issue of stigma and fear that gets in the way. So I might go to the next one, which was from Paul. Can the panel address the potential role that broader access to innovative technologies can play in addressing some of the service issues, e.g. insulin pumps, simplifying titration, CGM, enabling real-time behavioural adaptation, and most importantly, point of care HbA1c in community.
Glenn, and then I'll go to Anne on that one.
So Norman, I would come back to the fact that CGM is not funded at the moment for people with type 2 diabetes, but we've been using it for the last few years, and it really gives us amazing insight, because the person with diabetes can see whenever they eat, and we can all see when they eat, the levels go up. They can see when they become low. And having just come back from the American Diabetes meeting, we're thinking of CGM more as a therapeutic intervention, which if you get people to wear it and watch it, we see their diabetes blood sugar levels come more into range and things really improve.
So it's
So
a
that would be
biofeedback mechanism.
Yes, because it's a great behavioural feedback. It's a great change, and they teach themselves. And then they say, oftentimes patients will say to me, people with diabetes come in the clinic will say to me, oh, this is the first time I've really understood why things are the way they are. And over the 2 weeks they're doing it, you can see things improve dramatically. So that would be my one pitch. I think in terms of technology, I've touched on the use of apps and the use of educational material. And I think that as everyone has on their word AI, I think there's going to be a big play in there. Things will change, I think.
Anne?
Yeah, exactly what Glenn said. I think we need to be able to access the use of CGM more broadly. So not just with our people with type 1 diabetes, but also with our people with type 2. I've been using it a lot in type 2 as well, particularly the people who are on insulin, but also having a look at newly diagnosed people with type 2 and their ability to wear it for a few weeks so they can understand the effects of their lifestyle intervention. When we're talking about pumps, the pump technology is improving all the time and becoming less user intensive. So the pumps are starting to think for themselves now. And as that technology improves, I think that's going to help. Again, it's mostly for our type 1s, but we can have our type 2s on pumps as well. And the other thing is the use of being able to share data. And so, like Jackie said, the diabetes educators there at the end of the phone or the email, can you have a look at my data? And we can help them interpret some issues that they might have and be able to get to them really quickly so they don't have to wait weeks to see us. So, you know, using telehealth, using the shared data, all of those things make things a bit easier.
The only thing around that, Norman, is while the technology is fantastic, there's not been any additional billing items or any support funding for healthcare professionals to teach people how to use this technology and to review it. So once upon a time, someone would come in and they might show you 4 blood glucose levels per day for a week. And so you had 28 glucose levels to have a look at. You could quickly have a look at that and make some adjustments. Now there's a glucose level every 5 minutes. So that's 288 glucose levels a day across 7 days. It's a lot of data to look at and to interpret, and it takes more time. The AI will help that over time, no doubt. There'll be smarter tools that will help us to identify things more quickly. But at the moment, there's been a huge uptick, huge upshift in the use of technology, but no additional support for healthcare professionals in terms of training, billing items, more healthcare professionals, positions available, et cetera, et cetera. So it's just been a burden on the healthcare professional service, not that the healthcare professional service has coped with it, mainly probably by just working extra hours. So we don't see it as a burden because we really care for people with diabetes and we want to look after them the best that we can.
We're very passionate about looking after our clients, and we'll do a lot of pro bono work, lots and lots of hours of pro bono stuff just to helping people out.
But there needs to be support for this.
Time for one more, Tim.
Lots more comments coming in around that issue of fear and stigma and the sense that people anticipate being judged if the results are not within range or target range. So a lot on that. I might come to this final one from Connie. Access to expert services is difficult generally, but when add in living in regional areas, this creates an even larger challenge to get access to services. So the question being, how can we improve the gap between regional and metropolitan service provision?
Conrad?
Yeah, look, that's a great question, Connie, and it's something which is reality that we're never going to have enough endocrinologists, enough CDs for everybody to have somebody close to home all the time. And certainly telehealth has helped. But I think a big part of also we go with that fear and stigma is that we've got to remember that you aren't just data once you have diabetes. You know, these are still people. The concept of so often I have my patients come back after they've been to the diabetes centre and they've been grilled by the endocrinologist about, why are you having all of these lows or why are you having all of these highs? And nobody's actually asking, are you doing okay? What do you actually want? And actually getting to that's where making sure that your GP, who you do have access to, even in regional areas, is part of it, that you don't let your diabetes become dissociated from that relationship you have with your GP. It's not just something is between you and the endocrinologist or you and your CDE and the GP doesn't get linked in. Because if you've got your GP linked into that whole team, then you are going to have that advocate, that local advocate who can explain things, empathise with you, get you through the whole picture, not just what's happening with your sugars, but also smooth you through those bumps in the road when you haven't got access to the specialist care that you might have been looking for.
Well, look, thank you very much to you all for, I'm glad I made it in the end electronically because it's been illuminating. I've learned a lot. Apologise to anybody who I insulted in my questions, not on the panel, but listening. But the fascinating discussion, really important discussion, because we, for all the people living with diabetes watching, I mean, these things, getting your regular checks, making sure you're as healthy as you can be and the risk factors as low as they can be, so you live as normal a life as you possibly can, which is hard at times, I know, but so that you're not mugged by something that could have been prevented. And the system needs to change. And everybody watching this has to take part in advocating for that system change. And it's complex, as you've heard, but there are solutions there. And I'll hand back to Justine.
Thanks, Norman. Great conversation and thank you very much. So I have been given the privilege of trying to summarise all of that. So let me have a very quick crack at it. It's complex and there is a true mental burden of living with diabetes. It's very real. Stigma is also real and we always need to be remembering that nobody chooses diabetes, nobody does. Criticality of understanding the difference between type 1 and type 2 and that nothing stays the same for any individual at different ages and stages. But we all need to be very clear that this is not a competition between type 1 and type 2. We're all in this together. It's tough for everyone, particularly challenging for the newly diagnosed and parents, and particularly challenging for our vulnerable teenagers who we need to wrap support around and never, ever forget in all of these conversations that we're having. Information and understanding what foods impact individuals can be very valuable, and the increasing value of CGM, and a really good comment that came from Brett around, can AI help more and what is the future of AI there? Access to primary care is critical. It is a time-consuming and expensive illness to have when you have diabetes, and primary care is absolutely key to ensuring prevention, early diagnosis, early intervention, and reducing complications. The absolute immense value of diabetes educators and the workforce in general, and making sure that we are continuing to promote the very strong role that diabetes educators have within our complex health system. Making sure that there's sufficient access to Medicare billing numbers, and we need to change the way our health system works to put the support at the top of the cliff rather than the ambulance at the bottom of the cliff. The Medicare system as we know it is not currently fit for purpose. I also wanted to add that conversations like this for some people can be quite triggering. We understand that. We have support please go to the Diabetes Australia website if you need it. We're always here to support you. And likewise, we will welcome all new members to Diabetes Australia with open arms. The more people that we can get having this very impactful, bold and important conversation, the better. We have a unique opportunity at the moment with the parliamentary inquiry into diabetes, and the more voices that speak up, the more powerful it will be. So thank you to our panellists. Thank you to all of you who have joined online. And for those of you who'd like to come again tomorrow night and the night after and the night after, we were continuing to debate a series of other topics over the coming days. Tomorrow is in Melbourne, but online also. The brain drain: is diabetes research in Australia in crisis? Thank you, good night, and thank you so much for being part of our very special community of people living with diabetes in Australia, researchers, health professionals, families and carers. We thank you. Have a great night.
Bye.